Good afternoon. I have not had time to go around and say hello to all of many friends and colleagues that are here today. And unfortunately, I'm going to have to leave right after I finish. But to all of you that I did not get to speak to, a warm hello this afternoon. What I'd like to do is spend a few minutes talking about a project that I completed with the Academy of Pediatrics in which we developed a toolkit. And we surveyed pediatricians around the country to get their input in terms of what should be included in the toolkit. And I want to share that resource with you this afternoon. So I'll talk a bit about what it means to deliver culturally effective care. I'll talk about the development of the toolkit. I'll give you the website architecture. I'll give you snapshots of what it looks like if you were to go online. And I'd like to introduce all of this through some case studies to sort of ground the discussion in our day-to-day practice. So let me start off with one case just to frame the discussion. So your last case of the day is a 6-year-old Latino male that was referred by the school nurse because of a fever of 40. His mother accompanies the patient but does not speak any English. The patient speaks and understands both English and Spanish. But your only on-train interpreter has gone for the day, and you only know a few words in Spanish. What are the next steps? If you're in the clinical practice and this is the case that you're encountering where there's a language barrier, what is your next step? Let's talk about what it means to deliver culturally effective care and the significance of it. If we look at the Academy of Pediatrics in terms of their Committee on Pediatric Workforce, what they describe is that the delivery of care within the context of appropriate physician knowledge, understanding, and appreciation of cultural distinctions. Such understanding should take into account the beliefs, the values, the actions, customs, and unique healthcare needs of distinct population groups. Providers will thus enhance interpersonal and communication skills, thereby strengthening the physician-patient relationship and maximizing the health status of patients. In a nutshell, what it means to deliver culturally effective care is to be able to deliver care within the context of your patient's ethnocultural framework. So if you look at the IOM in terms of their quality, the things that they center quality around, there are different pillars: safety, effectiveness, patient-centeredness, timeliness, efficiency, and equity. Equity is the one that probably you read about the least in terms of the literature that's been published. Basically, it means no variation in the quality of care that are based on the patient's personal characteristics, including race and ethnicity. So any kid that comes to our practice should receive the same level in terms of quality of care. Mark made the statement in terms of the diversity within this group, but if you look at the U.S. population, the population is changing. And what this diagram shows is that by the year 2050, the people that are now considered minorities will be considered majorities. So there'll be a transformation. And some of that has already occurred in certain states and regions in the U.S. If you practice, for example, in California, or if you practice in Adams-Morgan in the District of Columbia, Latino children comprise the largest group of children. And by the year 2020, it's estimated that 1 in 5 children in the U.S. will be Latino. Let me talk a bit about the toolkit and how we went about developing. This is the group of other pediatricians that collaborated with me in this particular project. What we did was we first surveyed the pediatricians. We wanted to understand, and these are practicing pediatricians, not researchers. We wanted to understand, first of all, whether the pediatricians had questions regarding the delivery of culturally effective care. Issues such as language barriers, problems with interpretive services, questions regarding traditional practices, cross-cultural communications, and does any of this arise in the day-to-day practice of these pediatricians? And these were the results. That approximately 95% of them said that they did have questions regarding the delivery of culturally effective care. We went on to ask other specific information. We wanted to find out what kind of mechanism, how did they want these resources delivered, what would be most helpful. Most of them said that either a web-based resource would be most helpful. They needed materials for patients in other languages, and the third highest percentage was some sort of manual in terms of what did it mean to deliver culturally effective care. Another question that we asked in the survey was which specific topics needed to be included if we were to have a toolkit. These were the answers. You can read them for yourself, but basically the ones that had the highest percentage were conducting a cultural interview, how one deals with patients of other cultures, what are the questions that you need to ask as a practicing clinician, and then accessing community resources. This was the other area that the practicing pediatricians thought it was important to have those resources available to them. So we went about developing a website, and this is the architecture of the website. If you were to access it at practice.aap.org/culturally effective care. These are the different topics that are covered. It describes sort of the toolkit, and then it goes on to talk about very specific issues: child behavior and child development, continued medical education opportunities for the physician, interpretive services, health beliefs and practices, and the list goes on and on. So let me just walk you through a few cases and how you could use that resource to help you in the delivery of cross-cultural care in your own practices. Let's go back to our original case in which you had a patient that was basically monolingual. Well, the patient is bilingual, but the parent is monolingual, and there's a language barrier between the clinician and the patient's family. If we look at linguistic barriers specifically, in a study by Dr. Glenn Flores, he concluded that there are multiplicity of adverse effects that are associated with language barriers. How many of you have had a patient in your practice that speaks a language different from your own and you could not communicate with them without an interpreter? All right, take a look around though, because that's a reflection of the multicultural environment in which we all practice. So some of the things that are associated, if you will, some of these language barriers that are associated with these language barriers are impaired health status, non-adherence to medication regimens, and a higher use of resources. If we don't understand what the patient and the family are saying, it's likely that we're going to order more tests just to make sure that we cover all of our bases. In one particular study, it was identified that language was the most significant barrier as it relates to caring for Latino children. So the issue of interpretive services, it's become a bigger and bigger field because we're dealing with more and more patients from, that are monolingual or that have language barriers in terms of our particular practices. So having an interpreter is an essential component of the communication between a patient that is a limited English proficient patient and a healthcare provider. There are different kinds of interpreters. You can have professional interpreters. At Children's, we're actually privileged to have a team of professional interpreters. There can be ad hoc interpreters. Untrained family members, this is not the desirable route to use. And I have seen that play out in which children are used as the interpreter, and it can be harmful to the kid, and the parents are not really getting the appropriate information. You can have hospital employees or employees in the practice and complete strangers. The issue is that there are problems associated with using interpreters that are not trained. In one particular study, my colleague Glenn Flores compared what the interpreter said as opposed to what the clinician was saying. I'm originally from Puerto Rico. I was born and raised on the island, and my sister and I used to watch the Miss Universe contest. And whenever the Latina contestants would stand up and they would give their answers, they would give this long, expansive answers about why they should be Miss Universe, and then the interpreter would just sort of interpret 2 or 3 words, and that was it. And my sister and I would look at each other and we'd say, that's not what she said. That's not what she said at all. Well, in the clinical setting, it's the same sort of situation. The untrained commit many errors, and in one particular study where there was a transcript of what the communication was transcribed between the interpreter and the clinician, and there were some basic omissions as it related to drug allergies, past medical history. In one particular case, the interpreter told the patient to apply the antibiotic, to take the antibiotic for 2 days instead of 10, and in another one to use hydrocortisone on the entire body as opposed to in the particular lesion. So there are some significant errors that can occur if we don't use the right kind of interpreter. There's a section on the website that we developed that specifically looks at this issue of interpretive services and what are the pros and cons of using different kinds of interpreters, the different options that are available to the practicing clinicians in terms of interpreters. These are the sections of that particular part on the website. So the options that are available, the pros and cons, issues regarding cost and pay or payment. In many cases, this is not reimbursable, but in some it is. And the website goes into some detail as it relates to that. What to look for if you're contracting an interpreter, some pitfalls to avoid, tips for working effectively with interpreters, and then assessing the need for the patient for interpretive services. So these are the sections that are included on the website. I just wanted to give you just that screenshot as it related to the pros and cons that are associated with different options. If you look at the language line option using trained independent interpreters, there's some video conferencing capabilities, not necessarily in the regular practice, but in some academic health centers, they do have those capabilities. And then using on-site interpreters. So I leave that just basically to whet your appetite so that you go to the website and see what kind of resources are available to each of you as practicing clinicians. Let me walk quickly through the second case. You've been treating a 7-year-old kid with severe and poorly controlled asthma. The parents refuse to use the inhaled steroids as prescribed, and they continue to rely on traditional medicine. What are the next steps in terms of managing this particular patient? As we look to this issue of asthma specifically, and a fair amount of work has been done in this area as it relates to what the scientists refer to as sociocultural determinants of health. One of the things that was found in looking at asthma disparities is that African American and Latino kids, in this particular study, they were all enrolled in Medicaid managed care programs, they had worse asthma status, and they were less likely to use the preventive medication. And even after you adjusted for socioeconomic status, the disparities still persisted. And we pose that some of this is related to issues such as language barriers. Scientists refer to these different sociocultural issues as sociocultural determinants of health. So that relates to the parental and child health beliefs as it relates to asthma, for example, the knowledge, the competition for other basic life needs, and then environmental factors. If a family lives in an area that is very environmentally polluted and cannot move out, then that is a factor that is affecting that particular child. Some of the racial and ethnic differences in health beliefs and concepts of diseases, differences in terms of the value of steroids, prevention, the fear of steroids, and then a lack of regularity in terms of these patients' day-to-day lives. So when we're dealing with a situation or a condition such as asthma, the basic way that we control it has to do with medications, but some parents have strong beliefs against the use of medications, particularly as it relates to steroids. In one particular study, 60% of Dominican mothers believed that their kids did not have asthma if they didn't have any symptoms. Almost 90% thought that medicines were overused in the U.S., and 72% didn't use the prescribed medications. Instead, they used traditional practices. So if you were to guess what kind of practices these patients use, these are some of what they call the ethnomedical therapies. Some of them just relied on prayer. Some of them use Vicks Vaporub or Alcanfor. When I was a kid, my grandmother used to give us Vicks when we had a cold, not to rub it on our chest, but to swallow it. It's a wonder I have one neuron working today. Another traditional practice is siete jarabes, that means 7 syrups. Agua maravilla is witch hazel, and té de manzanilla is chamomile tea. So these are different alternatives, alternative practices. Usually they're benign. The problem is if there's nothing, if they only rely on this and disregard our approach or our therapy, sometimes it can be problematic. Not always, but sometimes. There is a section on the website that specifically relates to traditional practices, alternative medicine, indigenous healers. This is the snapshot of the screen, what it looks like. Many, many tools and resources. When I started working in this field a couple of decades ago, there were very few tools that were available to clinicians. Now there are many that are available. We didn't recreate them in terms of this particular project. What we did is create the links so that people could use the website to access some of these resources. I wanted to finish honoring Dr. Weissman's schedule, wanted to be on schedule, that culture by itself is not sufficient in terms of delivering culturally effective care is not the only thing in terms of these particular patients. I like the way Dr. Gregg concludes it by saying that culture in all of its richness does not simply explain health behaviors, nor does sensitivity to culture solve health disparities. Rather, culture works dynamically in conjunction with economic and social factors to affect health behaviors, and to alleviate or exacerbate health disparities.